Hi, welcome to our channel again. In this YouTube channel, we discuss about various professional exam questions of MBBS. So, I am Dr. Jyotirmoy Majhi. I have done my MBBS from Bankura Sammilani Medical College and Hospital. So, today's question is the role of complements in acute inflammation. The role of complements in acute inflammation. So this actually the complements chapter in my MBBS test or second prof test, I was perplexed about this topic called complement in acute inflammation. I was really perplexed because this pathway is the pathway of complements is really very much difficult to understand, and there are so much more diseases to understand also in complements. So today's question is role of complements in acute inflammation. So what is acute inflammation? What is acute inflammation? What is the purpose of it? The purpose of acute inflammation is to kill any of the infectious agent or any offending agent, tame of any offending agent in a very short period of time. So according to Robbins, what are the three major components of acute inflammation? That is the increase in blood flow, yes, vascular due to vascular dilatation, then increased permeability of those vessels. So due to increased permeability, plasma proteins and leukocytes come out of the circulation, and then those leukocytes which has come to the tissue space, they go to the exact locus of the inflammation, so that they can eliminate the offending agent. So that is the definition. Now, what role has complement in this inflammation, in this acute inflammation? Actually, complement is a part of innate immunity. So you know what innate immunity is. Innate immunity is totally undifferentiated. It is the primal immunity of any animal, that is called innate immunity. Whenever any antigen enters first in your body, your innate immunity activates. Now this innate immunity signals your acquired immunity, and now this acquired immunity system creates specific antibodies for that specific antigen. So but this complement system is totally undifferentiated. It acts it acts samely against anything. So what is complement system? Complement system is a collection of soluble proteins and membrane receptors. So not only proteins, also membrane receptors that function mainly in host defense against microbes and in pathological inflammatory reactions. So that is complement. That is the role of complement. So now we have to know where complement protein genes are located. So complement genes are located in chromosome 6p. So have you heard about chromosome 6p? Short arm 6p, p means short arm of chromosome. Yes, you have heard that major histocompatibility complex proteins are translated from these genes, located in 6p locus. So there are more than 20 proteins associated with complement system. Most of them are synthesized in liver, and they are present inactivated. They are usually inactivated, and due to presence of any offending agent, they are activated by proteolysis. Now you may have heard this term called minor histocompatibility complex, which is present in chromosome Y. Minor histocompatibility complex. Now there are three types of MHC proteins: MHC class 1, MHC class 2, MHC class 3. All are located in 6p of chromosome. So MHC class 1 is HLA A, B, C. You have heard about this, I think. So HLA A, B, C are present in all nucleated cells of body, all nucleated cells and platelets also, and they are detected by CD8 T cells. So first, so what happens? Whenever any antigen enters, the macrophages etc. Take these antigens to the CD8 T cells, and CD8 T cells detect them through these MHC ABC receptors. Okay. Now MHC class 2, DP, DQ, DR etc. they are associated with various autoimmune diseases etc. like diabetes mellitus, in case of diabetes mellitus, rheumatoid arthritis, SLE. In case of SLE, DR3 more than DR2, and in case of your rheumatoid arthritis, DR4, DR1 etc. are associated with. those MHC HLA antigens associated. Now our focus, now these MHC class 2 proteins are present, class 2 receptors are present in professional antigen presenting cells, like I have told you about Langerhans cells in previous video, B cells, macrophages, etc. And they are detected by CD4 T cells. Now these CD4 T cells take them to other lymphocytes, and they differentiate and they create those specific antibodies for those specific antigens. That is the part of acquired immunity. Now the complement proteins, where complement proteins come, they come in the MHC class 3, the MHC class 3, but C3, only C3 is not translated by those MHC class 3 genes. TNF alpha is a part of them. Lymphotoxins, a heat shock protein 70, 25 hydroxylase enzyme, 25 hydroxylase enzyme is associated in vitamin D synthesis. You know about this vitamin D synthesis. 25 hydroxylase enzyme is associated. Now this is a very much complex pathway that we find difficult to understand in case of complement. So I have made a much more understandable thing for myself, and I will tell you about this. So there are 3 pathways for complement. There are 3 pathways. That is classical, that is another is microbial carbohydrate mediated. First one is classical microbial carbohydrate mediated, and another is alternate pathway. So why is it classical? Because it is activated by antigen antibody complexes. So which antibody are most commonly present? IgM and IgM most common in case of classical pathway. So classical pathway and mannose binding lectin or MBL pathway acts quite in the same way. So how do they act? They act by binding with C1 protein of complement. C1. Now they bind with C1 and they form C1 complex. So this C1 complex breaks the C1 is hydrolyzed into C1a. Now this C1a breaks the C2 and C4 into C2a and C4b. C2 and C4b. Now this C2a and C4b joins and they form a complex called C2a plus C4b, which is C3 convertase. Let me change the pen. Yeah, C2a and C4b, and they form C4b plus C2a. This is C3 convertase. Now the C3 convertase for classical and MBL pathway is C4b plus 2a, but in case of alternate pathway, so what is alternate pathway? Alternate pathway is activated by endotoxins. Endotoxins are present usually in lipopolysaccharide layer, LPS layer of usually gram-negative bacteria, others also usually in gram-negative bacteria, and various complex polysaccharides. Cobra venom also activates this alternate pathway. And they, along with factor B-D propardin, they form 3B, capital B. This acts as C3 convertase in case of alternate pathway. So in case of classical pathway, C4b and 2a are C3 convertase. I have marked this, and in case of alternate pathway, it is 3b, BB. Now the main part is C3 hydrolysis. C3 hydrolysis is the main part where the cascade starts uncontrollably. Now this C3 hydrolysis happens, so C3b forms. C3b is very much important. C3b then in turn acts as C5 convertase. So convertase means C5 is broken into C5a and C5b. Now this C5a acts in a different manner, and C5b combines with C6, C7, C8, C9, and they form membrane attack complex, MAC. They form membrane attack complex. These membrane attack complexes, what they do, they form pore into bacterium cell wall. They form pores and they kill usually dangerous bacteria with thin walls like Neisseria, etc. And they can kill them. So what are the other complements? C5a, you have heard about this anaphylotoxin. C5a is C5a, C3a, C4a, etc. acts as anaphylotoxins. They initiate anaphylactic reaction, that is type 1 hypersensitivity reaction. And C5A also acts as chemotactic agent. So what do they do? They activate arachidonic acid metabolism, and they initiate this lipoxygenase pathway, and they form various chemokines. Like leukotrienes, etc. Okay. And C3b acts as an opsonin. So what do opsonins do? Opsonins are IgG, C3b, etc. are opsonins. They make the offending agent more palatable to the macrophage, or to the other to neutrophils, to phagocyte. So they help these killer cells to kill the bacteria. They help them to endocytose those offending agents. So this is the main step. You can write this much and you will get marks for this. So in Robbins, this picture is given. So C3b, so how C3b acts? C3b acts as opsonin. Phagocytosis happens, and membrane attack complex, that is through C5b to C9, and this is C5A, C3A. They act as chemotactic agents, helping recruitment and activation of leukocytes. This is alternate pathway. This is classical pathway, antigen antibody complex. I have said you. Lectin pathway, lectin, mannose binding lectin, microbial carbohydrate. Okay. This is another diagram. Now, what are the diseases associated with? If you write up to this much is sufficient for your professional exam question. This much will well explain your the question, that the role of complements in acute inflammation. So remember, this most important step in complement activation, complement cascade, is C3 activation. After C3 activation, all those things happen. Okay. Now, various complement system associated diseases. Most important among them is PNH, CD55 and CD59 deficiency. You have read about this. I will discuss also in short. I will discuss later. C1 esterase inhibitor. You have read about it also. Hereditary angioneurotic edema. Spelling mistake. Sorry. SLE. In case of SLE, various complement deficiency is present. C1Q, CR1R, etc. Pyogenic infections. One among the mnemonic, you can remember HUS, H for H, factor H deficiency. C3 deficiency is associated with SLE glomerulonephritis, i.e. lupus nephritis. Alternate complement pathway activation, it's associated with IgA nephropathy. And this is very much important for your MCQ questions. C5 to C8 deficiency is associated with recurrent Neisseria infection, property deficiency, meningococcus. Now, there are few diseases which can be detected with low serum C3. That is, the mnemonic is less BMA or anything you can make. I have made like this. Lupus nephritis, the important among them, MPGN. In case of MPGN part 1, classical MPGN, both C3, C4 is low, but in case of MPGN type 2, the C4 level is high, but C3 is low. And this is very much important, acute PIGN or acute PSGN. So what happens in those cases? IgA nephropathy, and key difference between IgA nephropathy and PSGN is, apart from other things, it is apart from biopsy differences, another difference is in IgA nephropathy, serum C3 does not reduce, but in PSGN serum C3 reduces. Okay, that is one of the differentiating feature which can be used to identify MCQs. Okay. So now I will discuss about this PNH complement disorder. So PNH is paroxysmal nocturnal hemoglobinuria. Paroxysmal means sudden, nocturnal means night, and hemoglobinuria because hemolysis is happening. So hemoglobin is coming out, and it is coming out in urine. So why does it happen? It happens due to deficiency of PIGA gene. This is one of the inesyl glucosamine transferase protein encoding gene. So what happens is this PIGA proteins, this PIGA anchors complement regulatory proteins. So what are the complement regulatory proteins? CD59, CD55, So CD59 is membrane inhibitor of reactive lysis, membrane inhibitor of reactive lysis or MARD. CD55 is decay accelerating factor, and C8 binding protein, that is C8 binding protein. Okay, these three are the complement regulatory proteins. So what does the complement regulatory proteins do? Complement regulatory proteins actually inhibit the complement cascade activation. Complement cascade activation, this is inhibited by these three proteins. So when piga which is present in the cell membrane, which is present in body cell membrane, which is actually glycophosphatidylinosytol anchored protein GPIAP, which is which binds this CD59 CD55 C8 binding proteins. So when piga is absent, when piga is deficient, these proteins cannot inhibit the complement cascade. So what happens at late night or during early morning, what happens? pH sometimes reduces, blood pH sometimes reduces. That can activate your complement system, or stress etc., other factors, infection etc., can activate your complement system. So there will be no CD55 CD59 to prevent this. So actually final path is complement cascade will be inhibited. And what is the final step? The final step of complement pathway is membrane attack complex formation, C5b to C9, that forms the membrane attack complex. Now they will create porins, they will create pores in your blood cells, and that will lead to hemolytic anemia due to RBC lysis, and WBC also will lyse, and platelet will also lyse. Okay, now what happens why as you know, platelets causes your blood clot. So deficiency of platelet should lead to more bleeding, not thrombosis. But the reason is because of the deficiency, the inactivation of your pro-uroplase receptor, that is pro-urokinase receptor that is present in your body, which lyses the clots. So that those enzymes cannot act. Now other pathways are there also, platelet activator, inhibitor, those will increase. C5a is a activator of the coagulation cascade, so that will also lead to thrombosis. Okay, so that will lead to thrombosis. Platelet activation will occur because there is ongoing inflammation. Now as there is membrane attack complex is formed, so that will lyse the cells. Now that will lead to tissue factor activation, that will lead to again your coagulation cascade activation. So that will lead to your uncontrolled thrombosis. So that's why most common cause of death in case of PNH is not in bleeding, but it is infarction. It is organ infarction, mostly hepatic venous thrombosis, that is Bart's-Chiari syndrome. So there low leukocyte alkaline phosphate score will be there, will be seen in PNH. Nocturnal hematuria, I have said this, and thrombotic episodes. So investigation of choice is not flow cytometry but FLAIR. But flow cytometry is usually done because it is usually available. So FLAIR more than flow cytometry because it has got more specificity. Actually PNH cases can convert into AML, so that's why every case should be ruled out. That's why FLAIR is used. Okay, treatment is eculizumab, which is anti-C5 monoclonal antibody. Now another disease is on the cards, that is hereditary angioedema. Okay, let me change the color. Hereditary angioedema. So why does hereditary angioedema happen? Hereditary angioedema is due to the absence of C1 esterase inhibitors. C1 esterase inhibitors actually they are proteases. C1 inhibitors actually inhibits the proteases, and they inhibit the complement cascade activation, and they inhibit factor 12 activation and kallikrein system. They also prevent kallikrein system. So what does kallikrein system do? Kallikrein system form your kinins like bradykinin. So what bradykinin do? Bradykinin is a potent vasodilator, which is a vasoactive substance, potent vasoactive peptide, which has short T half due to their constant degradation by kinase. But what happens when C1 esterase inhibitors are deficient? This factor 12A will be formed more, and kallikrein will also get increased. Okay, now that's why this bradykinin will get increased. Okay, because kinase cannot bradykinin, because there will be increase in bradykinin production. That will lead to your laryngeal edema, which is a severe complication that leads to life-threatening asphyxia, nausea, vomiting, etc., and mucosal edema, skin mucosal edema of GIT, etc. So this can be treated with C1 inhibitor, C1 esterase inhibitor concentrate that is prepared from human plasma, because complements are complement proteins, etc. Whole system is present in human plasma. Okay. Treatment of hereditary angioneurotic edema is methyl testosterone and stanozol, etc. These are androgen analogs. Okay. So thanks for the day. I am Dr. Jyotirmay Maji. So thanking you from my behalf and Dr. Kollan Das. So if you want more such videos from us, like, share and subscribe, and say in the comment section how if you like our video, and if you want any other difficult question to be explained, please comment below. Thanks for the day. Good night.